It's Mari McInerney from Croaky here at the Advanced Pharmacy Australia's conference in Adelaide, and I'm speaking here with Michael, one of the keynote presenters. Michael, could you introduce yourself, please?
Yes, my name's Michael Sorich. I'm a professor at Flinders University in the College of Medicine and Public Health.
And what was the title of your presentation today?
Oh, I think it was something along the lines of AI will complement me, not replace me.
Mm-hmm. And is that your big message? Is that...
I think it's an aspirational message in the sense that I don't think anyone knows the future. And I think it's about, aspirationally thinking, how do we have time, we know AI capabilities are improving, that it can be helpful to healthcare. It's likely to be very helpful if done properly. And then saying, well, what is the human element of it? I think that was where they were, directing it, and saying everyone is concerned that, there may be job displacement, job losses, and so forth. How do we take the opportunity that we have at the moment to, proactively work towards AI complementing us and helping humans to work better and to making the best of the capabilities of AI, but humans and working together and somehow result in a greater than the whole of those two parts, rather than it being a conversation mainly focused on how do we replace humans,
yes.
Right? And I suppose that's the idea.
And what have you found, like for pharmacy especially? We've heard quite a bit to date on what it's doing for medicine, etc.
Yeah.
But what about for pharmacy? What are you seeing that's good, and where are you seeing the drawbacks?
Well, to date there hasn't been a lot of implementation. So some of these technologies, particularly those which have really only occurred in the last 2 years, we kind of think about ChatGPT as like a watershed moment in terms of the emergence of really quite substantial improvements in capability, right? So it's really only been a short period of time, and in that time there's been a lot of experimentation. And it's probably rightfully so that there hasn't been any clinical implementation, because there's a lot of things to consider to make sure that this is done properly. So there's not much actually actually has occurred and that we can kind of get feedback on. Most of what's occurring is kind of more in an academic setting where we're trying to design studies and to kind of mimic ways and opportunities or tasks in the healthcare setting. Whether it's diagnosis, treatment selection, helping with clinical documentation, tasks that healthcare practitioners undertake, for example, and then trying to evaluate how well does the AI do that. And typically you would want to do that in as safe a manner as possible, which means typically we'd be very careful about using real life patient information. So a lot of them are kind of like synthetic examples where we write up examples that that don't represent any one person, so we can evaluate them without risking patient confidentiality. It's like an initial stage of trying to get a grasp on where does the capabilities of the AI sit, because that's really difficult, because it can be used for so many different has so many different capabilities, and there are so many different tasks that humans do in it, and it can be quite unintuitive to some degree, because we as humans may think that's pretty easy and that's pretty hard, but for the AI it may be the opposite way around, that what we find easy it finds hard, and vice versa. And it changes a lot over time as well as the AI gets better. So we have to keep on rethinking that, because we can't just say, oh no, we've decided that doesn't work for that, because that doesn't work, because the AI is improving often quite regularly. So this ongoing, trying to sense out, to feel out, where does it sit, and is it ready to even begin the process of doing more rigorous testing, and saying, well, there has to be a process to kind of, quite a rigorous process to kind of, move it forward. But we can't just start these large-scale randomized controlled trials for everything, right? Because that's a very expensive and time-consuming process. So you kind of start with smaller studies, and you kind of get a sense of which ones look to be, getting close to where they could be useful.
And is that being done strategically? Are you working with the sector or with industry or across the tertiary sector really? And also, are you following any particular countries? Are they doing it differently or faster? Or
I think it's a global effort, because like I said, most of the things at the moment are not reports of the research undertaking in implementation into a specific local healthcare system. often, like I said, these are kind of like case studies where you do it. So they often are quite applicable generally internationally. So a lot of what we're tracking at the moment is what's happening from studies internationally predominantly, but Australian researchers contribute to that as well. Because they're pretty standard kind of tasks, like asking how well can it work at diagnosis, how can it work at, well, can it work at selecting treatments. If I have a whole bunch of information about an individual in the hospital stay, how well can it summarize that for a discharge summary, for example? These are common tasks, some more clinical, some a little bit more administrative, but they're things that take time for healthcare practitioners, and you kind of trying to assess how well each of those work. And most of it has been, I think, predominantly undertaken in the context of medical practitioners. And there's probably good reasons for that. There's not a huge amount of information or studies regarding pharmacists, but I think a lot of them can be extrapolated quite similarly in a sense of there are similar cognitive tasks of working through decisions and similar kind of documentation tasks. So it would be good to see more specific work in the specific focus on hospital pharmacists working in clinical settings. But I think we can extrapolate a fair amount, at least to get a broad sense of which tasks are kind of emerging into, reaching a capability that is quasi-human-like, and hence maybe deserve a bit more effort to kind of really evaluate them really closely and properly.
But interestingly, I thought, as we spoke about just earlier, that dispensing would be the obvious area, but you poo-pooed that really. Where do you see the good areas?
I think pharmacists consider their roles more so these days, in the clinical realm, or a lot of that. I think dispensing has been kind of like a historical, maybe stereotype to some degree about what pharmacists do. And I think the ability, the skills and the ability of AI to work on dispensing has been something that's been around for a while. That actually those kind of capabilities are actually been around, and a lot of So I think these other ones, which are more highly cognitive, are probably the focus at the moment because they're the ones that just simply were not possible before. Whereas the things about dispensing, a lot of parts of it could have been potentially automated. And I think there's also the other element of it, which is that dispensing is often a physical activity, right? So a lot of that would require robotics and embodiment of the AI in a sense. You need something to kind of pick things up and to put labels on it and to move around. And robotics, it's moving ahead quite quickly, but it is probably further behind and higher. So those things will occur, but I think the first wave is going to be things that aren't physical, right? So that's probably where that holds that part back as well.
Now, what was your call to action to delegates here? Is it a call to individual pharmacists or to sectors, to settings? What is it to?
Yeah, that's a good question. My summary was that AI is progressing quickly, and it's unlikely that it's going to be stagnant. Like there's going to be continual improvements. It's unclear how quickly those improvements will occur, but it is going to get better, right? So keep that in mind, and that there's a lot of bureaucracy which is holding things back to some degree. So in healthcare settings, I think we're probably seeing less experimentation than in many other industries, and that's, I think, to a large degree, not unreasonable, right? But we do need to have a path forward. We can't just stall forever. But there's a pause to some degree, or a breathing space. This is what I think of it as, where we don't want to distinguish between things not happening in hospitals, meaning that it's not useful, or that there are fundamental technology reasons why it shouldn't occur. A lot of that's just working through system processes of how do we do this properly, right? So we have a period where we can try to plan out to say how do we want this to occur, and to kind of say that it's probably going to occur, right? So as pharmacists, as individuals and as a profession, to try maybe to embrace that, to kind of say I don't think it is useful to fight against that, because there's lots of potential benefits, right? We can help, if we do it properly, we can actually help improve healthcare, right? But as a profession, how do you want to do this in a way, there's an opportunity not to stop it, but to kind of be part of the conversation and hopefully have agency with respect to guiding the process and saying, how how do we choose what tasks, that we want to be worked on first? Because it's going to be a tough process to do this. You're not going to replace a job completely, in a sense, even if someone wanted to do that. You're going to replace tasks. You have to say, well, which ones do we want to focus on? And pharmacists or any professions hopefully can have some agency there to say, these are the tasks I think should be replaced. The ones which obviously AI can do well, yes, but also the ones perhaps that aren't as meaningful or that you just don't get as much fulfillment from, if possible, right? Saying, can we have some part of that? And how can we, if we decrease the work on a particular task, how can we reinvest that time, right? So it's not being about job cuts and cost cutting always, right? Kind of think about it. If you are forward leaning, is there a way to be part of this negotiation to kind of say, well, we can save time on this, but there's all these other jobs that we can't get around to, which are high value, that we can do, really help improve costs and health, and let's that be part of what the negotiation is for moving forward, and then try to be proactive about that rather than being responsive and saying, recalcitrant, and then the powers that be force it upon you later on. That's probably not the right way forward. So that's my call to action. And I'd say for pharmacists individually, they probably don't have a lot of control over that, because a lot of that's going to be in that leadership. But as individuals, to kind of be prepared for that, to kind of try to ethically, responsibly experiment, to work, to try to help to understand what it could be useful for and how, so you can be part of the process. And also not to try to be culturally, as a whole, not be a barrier to this, to try to be positive about this. That can help as well, in a sense of if there are well-guided thought processes of how we can implement this, it's going to help patients, but it's also considering the profession and individuals as well to embrace that and to be part of that, rather than reactionarily try to push back against that. Because I think to some degree, I don't know the time frame for it, but I think it's pretty inevitable that the capabilities are improving such that it is going to happen at some point, and I think you just have to kind of accept that to some degree, but to make sure it's done well. Yeah. I think that's where we want to be focusing.
Michael, that's fantastic. Is there anything else you'd like to say?
I think I've already spilled out too much, I suspect, and I think we've gone way over our time. Thank you.
Thank you very much.